at the Women's Fund for Health Resiliency, and we got to talking about what are some ways that we can just engage listeners. What are some important topics and ways of reaching other people in the community? And we thought, we teach these health classes at UHD. What a great way to bridge that gap. So now in our fourth year of collaboration, we continue to do that with UHD audiences and members of the community by bringing in health professionals and practitioners from all around Houston, those from the Kelsey-Seybold clinics to the Menninger Clinic, UT health professionals, those that are in private practice, and then nonprofit community organizations to have these important discussions on health issues that affect women. With this partnership, we've hosted an amazing set of series on topics including health disorders, heart health, anxiety and depression, violence against women, grief and trauma. And then today, our speaker, Dr. Patney, will be talking about reproductive health. So I just wanted to give a warm welcome. Thank you all for joining us today. I want to introduce Kayla from the Women's Fund, who will give our formal introduction to the guest speaker.
Thank you, Tony, for your introduction. The Women's Fund is so happy to be back partnering with UHD. We love this opportunity. We love to be able to bring in outside speakers to give these wonderful presentations. So before I introduce Dr. Patney, I'm going to talk a little bit about the Women's Fund. So we are a nonprofit in Houston dedicated to providing women and girls with the tools that they need to be advocates for their health. We do this through focused seminars like today's presentation, as well as curriculum-based classes and publications. All of our publications are completely free. You can visit our website, thewomensfund.org, to download free PDF versions or submit a publication request form for physical copies. And I highly encourage that you do so. Diving into the presentation today, we are very fortunate to have Dr. Patney here I'm so sorry about that presentation title, to discuss reproductive health. So Dr. Patney is a board-certified OBGYN at Kelsey-Seybold and a fellow of the American College of Obstetrics and Gynecologists. Prior to joining Kelsey-Seybold, Dr. Patney worked as an attending staff at St. Vincent's Hospital in Manhattan, Memorial Hermann Hospital, and Lyndon B. Johnson General Hospital, where she served as medical director of Obstetrics and Gynecology Clinic. She went to the University of Louisville, where she received her Bachelor of Arts, graduating magna cum laude with a major in biology and a minor in history. Dr. Patney earned her medical degree at the University of Louisville School of Medicine. She completed her residency in obstetrics, gynecology, and reproductive services at the University of Texas Health Science Center at Houston. When she's not caring for patients, Dr. Patney enjoys travel, reading, and spending time with her family. So we are so very grateful to have Dr. Patney join us here today, and I am going to turn the floor over to her so she can get started on her presentation over reproductive health.
Hello, hi, I'm Dipali Patney and I work for Kelsey-Seybold, and as we were saying earlier, I'm an OB-GYN and I see patients in a couple of different locations, predominantly over at Women's Center over by the medical center, and then I also have a location downtown. So we see all ages of women in our clinics through Kelsey-Seybold. So today we're going to talk about different reproductive health and fertility topics. Definitely open for questions at the end for anyone that has any questions about any material that we go over. It's a very broad topic, so I'm going to hit a couple of highlights, go into detail with some of the different topics, and then we'll kind of go into the question and answer session so that way people have time to ask whatever questions they would like. We can go on to the next slide. Okay, perfect. We can go to the next slide. All right, so reproductive health and related concerns. So some of the topics we're going to cover are your menstrual cycle. We're going to go over some birth control options and different, permanent, hormonal, non-permanent options. We're going to go over STDs, or sexually transmitted infections, STIs, the HPV virus. We'll go over vaccines and what the HPV virus actually does, some preconception counseling and fertility counseling, and then a disease process that we call PCOS, polycystic ovarian syndrome, and we'll go over some pregnancy and postpartum mental health. So the first topic, the menstrual cycle, everyone is familiar with it, but I think a lot of people don't know what is normal versus not normal. And the nice thing to know about your menstrual cycle is that there's variations of both. We could go to the next slide. Perfect. So first, let's talk about what a typical menstrual cycle is. And not everyone has a typical menstrual cycle. So when people talk about a typical menstrual cycle, they're talking about a 28-day cycle. And the way they get to that 28 days is the first day of flow is called day 1. And then after that, you usually will not start another cycle until 28 days later. So on day 1 is usually when flow starts. That can last anywhere between 2 to 3 days, all the way up to 7 to 10 days. Anything under 10 days can be normal. Most women are not going to bleed heavily for a full 10 days. Most women are going to have an actual flow for 2 to 3 days, or maybe even up to 5 days. And then after that may have very light flow or just spotting. Then women will then stop bleeding. Then where you're going to get into the phase of pre-ovulation. And then usually if you have a 28-day cycle, you're going to ovulate around day 14 or 15 of your menstrual cycle. After ovulation, most women are going to have no bleeding or spotting. And then about on day 28 or so, we'll start having another menstrual cycle. So the days around ovulation, days 14 and 15, are going to be your high fertility days. So if you're trying to get pregnant, that's when we're recommending women have intercourse. If you're not trying to get pregnant, those are days to avoid intercourse. Now, the variables come in the fact that not everyone has a 28-day cycle. A lot of women will have a 30-day cycle, or a 34-day cycle, or a 32-day cycle. And those can all be normal. The most important thing to talk about when you talk about your menstrual cycle is consistency. So if you have a 30-day cycle and it's consistently a 30-day cycle, then that is A-okay. Then that is still considered a normal menstrual cycle for you. If you have a cycle that's ranging 20 days sometimes, 21 days, and then 35, 40 days, and you're skipping months at a time, then that is different. That is going to be a much more irregular cycle. And at that point, we need to talk about what is normal and whether this is something we need to investigate. Now, certain times in your life, your menstrual cycle is going to be irregular, and it's okay. Oftentimes, after women start having their periods in their teens, they will not have a true regular cycle for years. I don't get too worried about a 15 or 16-year-old with still irregular cycles or not predictable cycles. When you're starting to hit your late teens and your early 20s, most women are going to have a predictable menstrual cycle, and that's when I would expect that cycle to kind of mature. Now, teenagers that are having very painful cycles or really heavy bleeding of their cycles, then whether their cycle's regular or not, that is something, though, that we do treat and take care of. All right, if we can move on.
I'm sorry, it's giving me some
That's okay.
trouble.
No problem.
Let's see where we are. Give me just a minute. I'm gonna have to pull it back.
Sure. No problem.
What is going on today? Okay.
Okay, so birth control. So now we're going to go over different types of birth control. And there's a lot of different options out there available. There are hormonal, non-hormonal, permanent, non-reversible, and then barrier contraceptions. So if we can go to the next slide. So we're going to go over all of these. So I like to categorize them. First, I'll talk about the barrier methods. So those are going to be something that prevents the sperm from getting into the uterus, into the fallopian tubes to fertilize the eggs. So you're talking about condoms, male and female, sometimes spermicide, sponge, something that is going to prevent the sperm from actually getting into the uterus. So the most common barrier methods that most people know about are condoms. Condoms, male and female. Those are the male condom and the female condom can protect you against STDs, so sexually transmitted diseases. The other barrier methods, such as a spermicide or such as a sponge, none of that is going to really protect you against a sexually transmitted disease. You're going to uh, want to make sure, or a diaphragm or a cervical cap. So those are also barrier methods. So the diaphragm or cervical cap actually puts a cover, almost is the way to think about it, over your cervix so that sperm and semen cannot get into the uterus. So I recommend definitely, even if you're using another form of contraception, that a barrier method should be used, such as a male or female condom, to prevent sexually transmitted diseases unless you and your partner both have been treated. So those are your barrier methods. Those are not going to, they're effective, but not going to be as effective as some of the other types of contraceptions that we're going to discuss. So the other types of contraception work differently. So first, then we're going to talk about hormonal methods. So hormonal methods, those are going to be your methods of contraception that use either estrogen or progesterone, which are two hormones that are naturally in your body, to prevent ovulation or decrease ovulation and to decrease fertilization. So hormonal methods, or solely hormonal methods, are usually going to have one of those hormones in them. So you've got the vaginal ring, the patch, oral contraceptives, an injection or implant. So those are all in the category of what we call hormonal. So we'll go through each one of those separately and give you a little bit more information on benefits and positives and negatives about each one. So effectiveness wise, the injection, oral contraceptive, patch, and vaginal ring are going to be in the same category. So pretty effective, 90+% wise rate of decreasing unwanted pregnancy. Implant is going to actually be a better effectiveness rate because it is it's one of the what we call long-acting reversible contraceptives, and we'll talk about that a little bit more when we talk about the IUD. So first, let's start with the vaginal ring. The vaginal ring, you guys may have heard of the name NuvaRing, which is the brand name of the vaginal ring, but it's actually now is generic, so it's often cheaper for a lot of my patients to get the vaginal ring now. But what the vaginal ring is, it's a little plastic ring, a couple of centimeters in size. It's very flexible, it's very soft. It has estrogen and progesterone in it. So what the ring does is it slowly releases estrogen and progesterone throughout the month. And the ring goes inside your vagina, like where a tampon would be, and just stays there for 3 weeks at a time. Over those 3 weeks, you are going to be getting a continuous amount of estrogen and progesterone through the vaginal mucosa. So your vaginal mucosa can absorb medication. So that is one way where we can get, one method in which we can get estrogen and progesterone to you. So what happens is with those 3 weeks of that ring in, you're going to be getting estrogen and progesterone, so you will not ovulate. It would prevent ovulation. And then after those 3 weeks are over, you yourself can take the ring out, just like you would take out a tampon, and you will have a week where the ring is not in, and that's when most women will have a menstrual cycle. After that week is gone or done, you put a new ring right back in. And once the new ring is back in, you start that 3-week cycle again. So 3 weeks with the ring in, 1 week with the ring off. So that is actually a very popular form of contraception that I do prescribe quite a bit because it's a little less maintenance than a birth control pill. So you don't have to remember to do something every day. Some women don't like it because it is something that you have to insert and take out yourself, but it does work quite well. Most women are going to have lighter, more regular menstrual cycles with the vaginal ring, just like with a birth control pill. The patch is another kind of lower maintenance form of hormonal contraception. And the patch is usually a little square. It's about 2 centimeters by 2 centimeters. It's not very big. And it just goes on your skin, and you change it once a week. So it's a little patch that you change once a week for 3 weeks straight. After the third patch is used, you go without a patch for a week, and that's when you have a menstrual cycle. So just like the ring, estrogen, progesterone is then absorbed through your skin, which is on the patch. So both of those have both estrogen and progesterone in them. Then let's talk about the oral contraceptive. So a lot of people are very familiar with birth control pills. It's probably one of the most common forms of birth control that we do use in the United States. Interestingly enough, it's not really the most common form of contraception outside the United States. So for oral contraception, there's multiple different types of pills that are out there. There's lots of different formulations. There are estrogen and progesterone based ones where it's the same two hormones that you get all 3 weeks, and then you go a week without any hormones, and you have a period during that time period. There's also what we call progesterone only birth control pills. So some women cannot take estrogen for any specific medical conditions. So sometimes women that have an increased risk of blood clots, or have had specific types of headaches or migraines, or have had other genetic high risk issues which prevents them from taking estrogen, we need to then put them on a progesterone only form of contraception. And that one of those pill types is a progesterone only contraception. The good and the bad with the birth control pill is, the good is it's easy. You just take a pill every day and it's very small. Most women are going to have really regular, predictable menstrual cycles on the pill. The bad is you have to remember to take a pill every day. And so if you don't remember to take a pill every day, you can mess up your cycle in the sense that you're going to be irregularly bleeding, or you can get pregnant. So that's where the failure rates kick in. I usually recommend taking the pill at the same time every day, so it becomes a habit, so that it's something that you're used to doing so you don't forget. So those are the birth control pills. The implant or the injection, we'll talk about the injections first. The injection is, most women will hear or have heard about it, called the Depo-Provera injection. And what it is a slow releasing medication of progesterone. So you get the shot every 3 months. Over that 3-month time period, progesterone is slowly released into your body, and it prevents ovulation. So the Depo-Provera, it's very convenient in the sense that you only have to come in to the doctor's office or see one of the nurses to get your injection 4 times a year. So every 3 months you get a shot. Most women after the first shot are going to have some irregular bleeding and spotting. After the second shot, for most patients, they'll either have regular predictable cycles after that, or for majority of my patients, they actually don't have periods at all. So that can be very nice. So the good things about the injection are that you do get, a lot less maintenance. You only have to come in and get it 4 times a year. You don't have to really remember something on a daily basis, so it's easier to remember. And for women with really painful, heavy menstrual cycles, it can be really helpful to help control their bleeding and their menstrual cycles. The negatives are, because it is progesterone only, sometimes progesterone has some of the side effects of increasing your appetite. So with that, we have to be very conscious and counsel our patients on making sure that they're watching their diet and that we're watching weight gain associated with that. Another progesterone only form of contraception that's available out there is the implant, or a lot of women will know it as the Nexaplon or the Implanon. So the implant is a little rod. It's a couple of centimeters long, and it fits right underneath your arm. I don't know if you guys can see me, but you can see it. You can't see it, but you can feel it. And it's very thin. We put it in the office. So it is a procedure done in the office, but it's very simple. We just numb up your skin and we slide it right underneath your skin. And that implant stays there for 3 years. So once you get the implant, you're pretty much covered for contraception for 3 years. So it has a very good success rate because there's very little maintenance that patients have to do for, making sure that the implant works. Once it's in, you don't have to think about it for 3 years. Some women really like the implant for the sheer reason that is something that they don't have to deal with. And it's good for a longer time period. So something that they're not having to constantly come in to get checked on or get refills on, and they're in control of that. The negatives with the implant is some more irregular bleeding than with other forms of contraception. That being said, for a lot of patients, they love it. And it suits them very well, and it works well for them for preventing pregnancy for sure. So those are the hormonal methods of contraception. Now we're going to talk a little bit about IUDs. So IUDs, there's hormonal and non-hormonal IUDs, and they fall in the category of what we call a LARC contraception, so a long-acting reversible contraception. The implant is one because it lasts 3 years. IUDs, depending on which one you choose, they can last anywhere from 3 years to 10 years. None of the IUDs have to stay in for that long. The IUDs can be taken out or removed whenever you're wanting to reestablish your fertility. So there's a couple of different IUDs out there. The one that is non-hormonal is called the copper T or the Paragard IUD, and it is a little T that is fitted inside your uterus. So we put it in the office. Usually I'm going to have patients wait till they're on their menstrual cycle. They're going to call on their first day. They come in, and we've usually done a gonorrhea and chlamydia swab ahead of time and counseled them on the intrauterine device. Usually I'm going to give my patients some pain medication that they're going to take the night before and the day of to help with cramping. And what we do is we actually just clean off your cervix. I measure the inside of the uterus, and then I put an IUD into the uterus. And what that little T does is it sits inside your uterine cavity with strings that come out through the cervix. The strings are going to be a couple of centimeters long outside of your cervix, which I can see when I do an exam. And what that copper T does is it slowly, because of the copper in it, causes an inflammatory process inside the uterus, which makes implantation and ovulation, implantation not occur and fertilization not occur. So that is how that's how the copper IUD works to prevent pregnancy. Patients really like it because it lasts 10 years. Also, there's no hormones. So if you are a patient that does not tolerate hormones well, this form of contraception has absolutely no hormones in it whatsoever, and it is quite effective. It is one of our most effective forms of contraception that are available. It does not have to be left in for the full 10 years. I'll have patients leave them in for a couple of years, and when they're ready to have a baby, then we just take them out. The other thing to keep in mind with the IUD is if your cycles are very heavy or very painful, the copper IUD may make them a little bit heavier, a little bit more painful than they naturally would be. I usually will put, I counsel patients on all IUD options, and I do use this one quite a bit. And a lot of patients are very happy with it, but that is just one kind of caveat to keep in mind. The other IUDs are going to be progesterone, um, have some hormone in them, the hormone of progesterone. So what progesterone is in there is embedded directly into the IUD. So when you put the IUD in, and they're all put in the same way through your cervix, that progesterone slowly acts on the lining inside your uterus and thins that lining out so that if there is any fertilization of the egg, it does not implant into the cavity because the uterus is not ready for an implantation to start a pregnancy. So that is how the hormonal IUDs work. And there's different ones that are out there. There's a 3-year one, there's a 5-year one, and there's 2 5-year ones. They range in the amount of hormones, and the higher the level of hormone is, the less bleeding that you're going to have. And for a lot of women that use the 5-year Mirena IUD, they will not have any menstrual cycles with those IUDs. The lower progesterone IUDs, most of my patients will still have some menstrual cycle, but usually pretty light, and then some irregular spotting. But after about 3 to 6 months after the IUD's been in, most of our patients are pretty happy with the IUD. The important factors with all the IUDs, because it is a foreign object inside your uterus, I recommend STD testing prior to placing the IUD in and having your partner tested also. And the reason is if you have an IUD with an STD at the same time, it can cause inflammation and an infection to go up into your uterus and your fallopian tubes. So if you have an IUD in and we do diagnose an STD, we need to treat it immediately so it doesn't spread throughout your reproductive organs. I think that is all the different types of contraception. And if anybody has other questions, oh, well, sorry, I forgot one more. Then also we're talking about the fertility awareness method. And I kind of briefly mentioned that of tracking your menstrual cycles and tracking when your high fertility dates are, and to avoid intercourse during those high fertility dates to prevent or decrease the chance of pregnancy. And then lactational amenorrhea, that means women that have, after they've had a baby, if they are exclusively breastfeeding, they will often not have menstrual cycles. And a lot of times, if you're not having a period, you're not ovulating. So that being said, neither one of those are going to be 100%, but they do decrease fertility by tracking your monthly fertility days. Or if you're exclusively breastfeeding, then you are going to be less able to get pregnant due to the fact that you're not ovulating. All right, I think we can go to the next one. All right, now we're talking about permanent methods of birth control. So this is going to be female or male sterilization. So male sterilization is called a vasectomy. That procedure is permanent. Now you can try to do vasectomy reversals or tubal reversals, which we'll talk about in a minute, but not always are the success rates all that great for them. So you would only choose this form of contraception as if you are 100% certain that you do not want any future fertility. And the vasectomy is usually done by urology. It's an office visit. They go in, see the doctor, they'll have a consultation, and then it's a procedure usually done in the office. And after the vasectomy is done, they usually have to submit semen analysis for a couple of months to make sure that the sperm count goes all the way down to 0 before they say that the vasectomy is good and you are not able to get pregnant. Female sterilization, then you're talking about having your tubes tied. A lot of people will talk about that. It is permanent. There's not a reversible, it can be reversible, but there's no such thing as tying your tubes and untying your tubes, because when we tie your tubes, we don't just tie them. We have cut, we've tied and we've cut and then removed a 2-centimeter portion of the fallopian tube out. So that is usually something that is done in the operating room. And what we'll do is we'll put the patient to sleep completely and under general anesthesia. And sometimes we'll do it at the same time as a C-section, so then you're not completely asleep. But then we're going to remove a portion of your tube. That is considered permanent. The other way we'll often do them is if, years later after you've had babies or you've never had babies and you don't want any children, we can do what's called a laparoscopic tubal ligation, where we go in with a camera through your belly button and I either remove a section of your tube or we burn and cut out a section of your tube, or sometimes we remove the entire fallopian tube. And those are all considered permanent forms of sterilization. All right, so let's talk a little bit about STIs or STDs, sexually transmitted diseases or infections. We can go to the next one. So there's multiple different types of STDs that are out there. They can be transmitted from person to person. Some are more easily transmitted. Some are treatable. Others are not treatable in the sense of they are not curable, but we can usually control their symptoms. So let's start with bacterial vaginosis. So this one we don't really consider a true STD. It's a bacterial infection. It's an overgrowth of the normal bacteria that's in your body. But having a bacterial vaginosis infection or having a bacterial infection in your vagina can make you more prone to getting other STDs. And it is still something that we are definitely going to treat. So the symptoms of a bacterial vaginosis often is abnormal discharge or yellow discharge that has a foul odor to it or has a fishy smell to it. A lot of times I'll see patients in the office with this. We'll give them antibiotics to get it to be treated. So that is something that definitely, if you're having symptoms of, you want to either see your gynecologist to get those taken care of to prevent or decrease your chance of potentially getting other STDs. Chlamydia and gonorrhea are other two very common sexually transmitted diseases that we see. And we do offer STD testing every time you come in to see us. And you can go to multiple clinics that will do just STD testing. Gonorrhea and chlamydia is often done as a vaginal swab. So when I do a pap smear, I'll often offer doing gonorrhea and chlamydia testing at the same time. It's a little Q-tip and it goes in your cervix and it just has to sit there for a couple of seconds and we send it off. Another way to test for gonorrhea and chlamydia is through urine. So doing a first void urine specimen, we can also test for gonorrhea and chlamydia that way. Both of those can be treated, and we do give antibiotics with them both. An important thing to keep in mind with gonorrhea and chlamydia is, number one, as we talked about with the IUD, if you get either one of these infections with an IUD, there is a risk definitely of that infection going up into your fallopian tubes and into your uterus, which can cause something called pelvic inflammatory disease. And that is an infection of your uterus and your tubes. Patients can be in a lot of pain from that, have high fevers. Usually, if it's really bad, we have to admit you to the hospital and give you IV antibiotics. The concern with that, of course, is that it affects your future fertility, because you can have scarring in your fallopian tubes and in your organs, where your ovaries and your fallopian tubes attach to your ovaries from that infection, and can cause problems getting pregnant afterwards. So it's really important that, if there is a chlamydia or gonorrhea infection, that we treat it as quickly as possible, so it does not get a chance to cause long-term fertility consequences. So if you're under the age of 26, we usually recommend testing for this whenever you come into the office. So I'm going to offer that to everyone under 26 or above 26, but definitely under 26 years of age. We're going to want to make sure that we get you tested. And a lot of women don't realize they have gonorrhea and chlamydia. They won't have any symptoms. Occasionally, they'll have symptoms of abnormal discharge, but a lot of patients have no symptoms of gonorrhea and chlamydia, and we need to get them tested and treated. It's also very important with both those STDs that your partner gets tested and treated also. If your partner does not get treated, then you are likely to just keep giving it back and forth to each other, and we don't ever have resolution of those symptoms. And that just increases your risk of future consequences. Then we've got hepatitis. Hepatitis B and C are both transmitted sexually, can be transmitted sexually, and we would screen both of those when you come into the office, and we usually do it as a blood test. Herpes is also another very common STD that we will see, and it often comes up as a blister. So a lot of times you'll hear people talk about fever blisters or cold sores. That's a herpetic cold sore. So there's two strains of HSV, herpes simplex virus, and it's HSV1 and HSV2. So 1 is usually associated oral, and 2 is usually associated genital. That being said, we do see 1 and 2 in other areas of the body. And they will both look like a blister. Oftentimes on your bottom, it'll be very painful. It hurts when you pee, it hurts when you sit, and it looks like a little pimple or a blister that's very painful to touch. So if that happens, I will often send a culture where I'm actually growing out the type of herpes, so I know which type it is. There is treatment for herpes, and we'll start patients on a medication called acyclovir or valsalcovir. Both of those are used to treat herpes and to decrease the amount of time you have an active lesion. So neither one of those medications get rid of herpes, because herpes there's not a cure for, but it controls the actual outbreaks. So a lot of patients, depending on which strain they have, 1 is usually a little bit more mild than 2. They may or may not get outbreaks after their initial outbreak. Some patients will have them frequently, every month, every couple of months. Other patients may go years without another outbreak. The important thing to keep in mind is when you do have an outbreak, that's when you're most infectious. So at that time period, you want to make sure that you're not being active with another partner, because it is a skin-to-skin contact transmission for herpes. And if you have an active lesion, to also begin treating it, because then what happens is the medication decreases the time that you have the active lesion, also decreases your viral load, so there's less chance of you passing it on to your partner. Patients that get frequent outbreaks, sometimes I will put them on herpes suppression. So what suppression is putting you on a Valtrex or, valcyclovir or acyclovir medication on a daily basis to prevent outbreaks from occurring. Also, to decrease the chance of you transmitting it to your partner. When patients are pregnant, if they have a history of herpes or they've had cold sores or any lesions on their bottom, we're going to start them on those medications toward the end of their pregnancy to try to prevent the chance that a lesion would occur at the time of delivery. If you have a herpetic lesion at the time of delivery, then we do not recommend proceeding with a vaginal delivery at that time. At that point, we recommend a C-section because you can transmit it to the baby at the time of delivery. So herpes is definitely something that we do see a lot and we do treat quite a bit. And it's important to realize that it's a skin-to-skin contact infectious. And then we have HIV/AIDS, which most people are aware of, which is also transmitted through sexual intercourse and through, it's a blood-borne disease or body fluid-borne disease. So transmitting that from person to person, either through intercourse or sharing needles, anything that kind of is a passing of fluid, body fluid. So we definitely offer that testing every time patients come in, like we do for hepatitis, and that testing is done also through blood. If you've had a potential exposure to an STD that you're aware of, you can come in to see the doctor and we do a full panel. And if you are not aware of your partner's status and you're worried that you may have been exposed to an STD, I usually recommend testing again in a couple of months. And the reason is not all of those show up immediately after contact. So it may take a couple of months for us to see like a hepatitis or an HIV in your bloodstream, or even the herpes or the chlamydia and gonorrhea. So I usually recommend repeating STD testing in a couple of months to try to make sure that we have not missed anything. And also, this is a tough conversation to have, but an important conversation to have with your partner before becoming sexually active, to have a conversation whether they've ever been tested or not, and to see if they'd be willing to get tested before having intercourse or stopping to use a condom, because you want to definitely make sure that you're using a condom until you know the status of your partner. Okay, and we talked a little bit about pelvic inflammatory disease. So that was the disease process that I was talking about, where there's an inflammation of your uterus and your tubes. And definitely, that's a much more severe form of an infection, in the sense that can have long-term consequences. You can be admitted to the hospital where you are having to have IV antibiotics. The other thing that worries us about pelvic inflammatory disease is it can cause large abscesses on your fallopian tubes around your ovaries. And when that happens, sometimes, unfortunately, we have to do surgery to actually remove portions of your fallopian tube, your ovary, or any infected area, because we're unable to get you better through with just antibiotics. Another sexually transmitted disease that we do test for is syphilis. Syphilis it does have symptoms, but a lot of patients will not have most of those symptoms or not realize that's what it is potentially from. And so that's also tested through blood. And depending on how long you've had the potential syphilis infection, we may have to treat you for a longer period of time. And usually we treat you with penicillin. So it's an injection. And syphilis can be treated and can be cured, but may take a couple of weeks of repeat penicillin injections before we're able to get rid of all the syphilis disease process. Trichomonas, which is another sexually transmitted disease. A lot of times patients won't have symptoms of it. It is a parasite. And oftentimes we will catch it also when we're screening for gonorrhea and chlamydia. So when I do a swab for gonorrhea and chlamydia, I also have the ability to do one for trichomonas. It is a sexually transmitted disease that's treated with antibiotics. It can be treated, but once again, this one, you and your partner both have to be treated at the same time, and to refrain from intercourse until we know that the infection is gone from both parties. Otherwise, you'll keep giving it back and forth to each other. It is something that we can test for in the office. Sometimes I know exactly that day I do a microscope slide for patients that are complaining about vaginal discharge, because that can be one of the symptoms of trichomonas, where you have some abnormal vaginal discharge, a kind of a greenish color. So that's what we're going to screen for that. All right, if we can move on. HPV, so human papilloma virus. A lot of patients have heard about this because there's been more information about HPV since the HPV vaccine has become available. So what's HPV? If we can go on to the next slide. What is HPV? So we're going to go over this a little bit. So HPV is a very common sexually transmitted or skin-to-skin transmitted virus. Almost 80% of the population, adult population, at some point has come in contact with it or has had HPV. There's a lot of different types of HPV out there. So there's some that we consider high risk and others that we consider low risk. So the high risk ones are definitely the ones that we're more worried about. Those are the ones that can cause genital warts or different cancers. And one of the cancers that definitely we're going to talk about is cervical cancer. So the HPV virus can cause different cancers and genital warts, but there's also a vaccine that has been made to treat the virus. So actually, I take it back, not treat the virus, but to prevent you from actually getting the virus. The vaccine is usually given when you're a kid. So the age range, we start at 9 years of age and up to 26 years of age. They just recently changed the guidelines and we can give it up to 40 years of age. Not always are all insurances covering it if you're over 26 years of age, but between 9 and 26 years of age, this is one of the common vaccines that I'm giving all the time. And to be honest, in the last couple of years, the pediatricians actually are doing so many of these that most young women that come to see me have already received this vaccine from their pediatrician. And what the vaccine covers is the most high-risk types of HPV that have been associated with cervical cancer. So the people that should get vaccinated, it kind of goes over it on that slide. We want to get you vaccinated as early as possible. Before you've been sexually active is optimal so that you've never actually been exposed to the HPV. But even if you have had a strain of HPV in the past or you've been sexually active, you could still get the vaccine because there's multiple strains that are in the vaccine that are covered. So you may have only been exposed to one strain of HPV. And so it's important that you talk to your doctor about HPV if you have not gotten the vaccine. HPV does cause cancer, and it can cause cervical, vulvar, vaginal, some skin cancers, can cause genital warts. So it is something that we do see a lot. When we do a pap smear, one of the things I'm screening for is HPV. So I'm screening for cervical cancer and human papillomavirus to see if a patient has it. If a patient has HPV, they're more likely to have cervical cancer in the future. Now, a lot of women may be able to slowly fight off that infection. The younger, the healthier that you are, the more likely you are to be able to get rid of the HPV virus. Another question that's on here is, will having HPV affect my pregnancy? So if you have HPV and you're pregnant, as long as your pap smears are normal, we don't usually do anything treatment-wise during pregnancy. We're gonna wait until you deliver. Now, if you have genital warts when you are pregnant, that is something that may get bigger when you're pregnant just due to the compromised immune system. So that is something that we do keep in mind when you're pregnant to keep track of. And it's just important to keep up with your cervical cancer screening, which is your pap smears. All right, preconception. So we'll talk about that briefly. And I want to leave time for questions, so I'll probably just go through this a little bit more briefly. So if you are considering having a baby or getting pregnant in the near future, I recommend coming in to see your gynecologist just for physical exam. Make sure you're up to date on your pap smear and make sure there's no lab tests that we need to do. Usually I'm going to talk to you if you have any chronic medical conditions such as diabetes or high blood pressure. That can cause high risk pregnancy issues, and that's something that we'll go over. The other thing I'll often go over is all the medications patients are on to see which ones are safe to be continued during pregnancy or what we may have to stop before you try to get pregnant. Before you get pregnant, I don't usually limit, patients on the amount of caffeine or that they're drinking. I definitely recommend stopping smoking always, whether you're trying to get pregnant or not, but especially if you're trying to get pregnant, because number one, it can make it harder for you to get pregnant. And we definitely don't want you smoking while you're pregnant. You want to make sure that you're watching your diet and very healthy foods, and you want to get your weight under control as much as possible. The reason that's really important is it's better or easier to get pregnant, and the pregnancy is also much more comfortable if you're physically fit and at your optimal weight. It also decreases your chance of developing high blood pressure, diabetes, or having a C-section during your pregnancy if you are as healthy as you could be before you actually get pregnant. Fertility. So we'll talk a little bit about fertility. All right. So as we were talking about earlier, many factors can affect fertility. Age is a large one. The younger you are, the easier it is to get pregnant. The regularity of your menstrual cycles. If you have regular, predictable menstrual cycles, then you're more likely going to have an easier time getting pregnant. Stress is definitely not helpful when you're trying to get pregnant. A past history of sexually transmitted diseases can cause issues with pregnancy if there's been any scarring of your fallopian tubes. Also, the term anatomical variations, the reality is that they're not that common, but definitely if you have lots of fibroids or polyps and you're trying to get pregnant, that can cause problems with fertility. And so that, if you're having if it's taking a long time to get pregnant, that is something you would want to see your gynecologist about. So infertility is, the definition of it is attempting pregnancy without any contraception or preventive methods for a year and not able to get pregnant. So 80% of patients are going to be pregnant within a year of attempting pregnancy. Most patients are going to get pregnant earlier than that, and usually in a couple of months, but it's not necessarily immediately. So that is something to keep in mind. If it's taken you a year and you haven't been able to conceive, then that is a time to come in to talk to us, because we need to figure out what's going on, because most people will be pregnant. So a couple of different things that we talk about trying to get pregnant: basal body temperature. So basal body temperature chart is a chart where you check your temperature every morning before you get out of bed. There's usually a peak or a spike of temperature right before you ovulate. Ovulation predictor tests are tests you can just get in you can get them at CVS, Walgreens, any sort of drugstore. And the instructions in the test usually tell you to test every morning or every evening. Just pick kind of the same consistent time of the day. And it's checking to see when your highest fertility days or ovulation days are, to make sure that you are active during those days to attempt pregnancy. And then, of course, at over-the-counter pregnancy test kits, they're actually pretty accurate. So that is something that you can definitely just get over the counter and try those. And if they're positive, then of course call your OB-GYN. So we are getting pretty close to 3 o'clock. I will just quickly kind of buzz through this. Obesity and fertility, definitely the more obese or the higher your BMI is, can decrease your chance of getting pregnant and does increase your complication rates with pregnancies. Lots of times it will prevent you from ovulating. So if you are not ovulating, it is difficult to get pregnant. The same happens with being underweight and fertility. So if your BMI is too low and you don't have any body fat or enough body fat, what will happen is you will not menstruate. And if you're not menstruating routinely, then you're likely not ovulating. So once again, that can also be difficult to get pregnant if you're not ovulating on a regular basis. So weight is a factor. We kind of want you what's a healthy weight for you to have regular, predictable menstrual cycles. Age. So age is definitely a factor in fertility as you get older. It is harder to get pregnant for a couple of reasons. Number one, your eggs, you have less eggs. You're born with a finite number of eggs, and once you're done with the eggs, you don't make any more. The other thing is the eggs may not be as the quality of the egg may not be as good, and the genetics of the egg may not be as good. So as you get older, there is an increased risk of difficulty getting pregnant. There's an increased risk of miscarriage. There's also an increased risk of genetic abnormalities, which can happen as you get older. Now, that being said, there are things that we can do for infertility, and that's a pretty long topic of all the different types of infertility treatments that are available, but definitely that's something that you would talk to your OB-GYN about. Endometriosis can also affect fertility. It is a disease process where There's endometrial implants all throughout your pelvis. And what an endometrial implant is, kind of like the lining inside your uterus has migrated to outside your uterus. We're not really sure why one patient gets it versus another patient. Well, you might see it more in specific families, but a lot of times patients will just complain of really painful cycles or just continuous pelvic pain regularly. Also, some of these patients may have a difficult time getting pregnant due to scar tissue of their fallopian tubes, inflammation, or just having endometrial implants throughout their pelvis. And that is something that we do treat medically and surgically. This is just a little brief picture of your anatomy, and what is showing you is two different ovaries. The one that is smaller is going to be your normal ovarian kind of appearance, while the other one is called a polycystic ovary, which has a lot of little follicles in it. So what is PCOS? The best way to describe it is it's a hormonal imbalance that we see a lot in women of reproductive age. Most of the symptoms of PCOS are going to be irregular menstrual cycles. So either long menstrual cycles or long periods in between your menstrual cycles, or infrequent menstrual cycles where they're skipping 2, 3, up to 6 months before they have a cycle. The other thing that we'll often see is patients that will complain of excess male hormone and increasing hair on their face, on their chest in a male pattern. It's usually coarse. They're complaining of the fact that they're having to shave or pluck or wax routinely. And that is just due to the elevated levels of testosterone that are in their body. Also, the ovaries can have multiple small follicles in them. And most of the time, not most of the time, but sometimes patients may have difficulty getting pregnant because they're actually not ovulating on a regular basis. And the other things to keep in mind with PCOS, that it's an excessive insulin disease process. So a lot of these patients are more prone to developing diabetes as they get older. Also, it is something to keep in mind that lots of times the treatments are going to be lifestyle changes, managing your weight. Sometimes I start patients on diabetic medications, which have shown to help regulate their menstrual cycles, and it helps your body process your own insulin better. So your body just works better. And the other thing will be birth control pills to make you have a regular cycle, because we don't want you to go that many months without a regular cycle, because it does cause excessive growth of the inside lining of your uterus. Pregnancy and postpartum mental health, we'll just briefly go over this so I have time for questions. So definitely, mental health is a very large topic, and I'm not going to go through all of these, but pregnancy and postpartum are very common time periods where patients may have an increase in anxiety or depression. Postpartum depression is also very common and something that we do need to be aware of and talk about. And so when you are pregnant and then after you deliver, we are continuing to ask you about depression and anxiety. We do check afterwards for postpartum depression, and that is something that we do discuss in the office routinely, and it is something that we do treat if we need to. All right, I wanted to leave some time for questions, so I will leave it open for questions.
All righty. So if you would like to ask questions, you can go ahead and add those into the chat, and I will ask the questions for you. If you feel more comfortable sending your question privately, you can send it privately to me. My name is the Women's Fund in the chat. So that is also an option if you want to send questions privately. We did have one question pop up in the chat already. Let me go ahead and open that up. And the question was, what about male birth control? So is there any news about that? I know a lot of options are for females other than the male condom. So could you touch a little bit on that?
So other than vasectomies and male condoms, I am not aware of any male birth control options that are out there. I don't treat men, so that isn't really anything that I am familiar with myself, and I'm not aware of anything that is routinely being done.
Okay. So the next question, is it recommended for females to visit an OBGYN regardless of sexual activity?
Yes, we are recommending that because depending on your age, we may not necessarily do a pelvic exam. I don't really do pap smears until you're 21 years of age. So you really don't need a pelvic exam prior to that. But a couple of reasons we would recommend seeing us is number one, we do a breast exam and we talk to you about your menstrual cycle, can talk to you about your future fertility, reproductive wishes. So that is definitely something I do recommend. Also to catch you up on any vaccines that need to be done, such as the HPV vaccine. So even if you're not sexually active, I would definitely recommend as you get older to see a gynecologist to go over some of the women's health care issues that we discussed prior.
Okay, so next question, are pap smears important to do every year?
So there's a lot of confusion around pap smears and pelvic exams. So those are two different things. Pap smears checking specifically for cervical cancer. Pelvic exam is when I'm taking a look inside your vagina, looking at your cervix, making sure there's no lesions, checking your uterus, tubes, and ovaries. So we recommend a well woman exam on a yearly basis, but we don't necessarily do a pap smear each time. And a lot of that is dependent on your age and what type of pap smear history you have. If you've had all normal pap smears and you've had a pap and we screened you for HPV and those are both negative, you can go a longer period of time without needing another pap smear. But we still do recommend coming in for a well woman exam, and then also a breast exam is done at the same time.
Great. So another question here. You said that women that have IUDs like Mirena usually do not get their periods. Is it a bad
Mhm.
thing if a patient still has their period while they have the IUD?
No, it's not a bad thing. If it's a regular, predictable cycle, it's not super heavy, and it's not painful, that can be completely normal.
What is the best way to get your menstrual cycle to be regular?
So it really depends on why it's irregular, on how to make it regular. Depending on how irregular it is, then we would have to, go specifically and make sure that it's not a hormonal condition, it's not your thyroid, there's not something else going on versus making it just regular.
And you mentioned earlier in the presentation when you were talking about the menstrual cycle that throughout your life it is going to change. Can things like physical or emotional stress cause changes in your cycle?
It can throw you off a little bit. Sure, if there's major lifestyle changes, stressors in your life, your cycle may be off, but it should go back to being normal. It's not going to be off for months and months at a time. The other thing that can really throw off your cycle can be weight. So, major weight loss or weight change can also throw off your cycle for a period of time.
Okay. Okay, next question. What age should a girl or young woman transition from a pediatrician to an OBGYN?
So a lot of that is dependent on both what they need and whether the pediatrician is comfortable managing it. I'll have some patients that'll stay with the pediatrician, 18, 19, 20 years of age. Some pediatricians are fine, and they're good and they'll take care of the patients up to that age. Most of our pediatricians aren't going to see them much past that age, and then you're going to transition to a gynecologist or a family practice doctor. They also do a lot of this stuff.
So another question, I'm on the pill and it has really helped me regulate my cycle, but I tend to get nauseous. Do you recommend I try to look for another option?
Yeah, so you could actually try the NuvaRing, which may not make you as nauseous, or take the pill at night before you go to bed, especially if you notice that you're nauseous right after taking it. You could potentially change the timing of when you're actually taking your pill and see if that helps that, when you're asleep, you're the most nauseous and it doesn't bother you. The other thing is you could potentially try the NuvaRing and see if you're not as nauseous with that. Sometimes it's just the hormone itself that makes you nauseous. And then what you might need to try is either lower dose hormones or a different contraception altogether.
Do you recommend endometrial ablation for excess bleeding during the menstrual cycle?
So it kind of depends on how heavy your bleeding is. Also depends on how old you are and whether you're done having children. So I wouldn't do an endometrial ablation if a patient was not done with, it's not recommended to do it prior to you're completely done having kids. The endometrial ablation can decrease your menstrual cycle quite a bit. You want to make sure there's no big fibroids, polyps, it's a normal sized uterus, and then the endometrial ablation may actually work well for you.
Next question. If I had an abnormal PAP but went the next visit and they said nothing was wrong with the biopsy, would it be possible to have another abnormal PAP in the future?
Absolutely, because HPV can be a transient infection. So you can get HPV, you can get rid of HPV, and you can get another strain of HPV. Just because you've had HPV one time and gotten rid of it does not mean that you will not get it again or your pap smear may not change. So that's why, we continue pap smear screening.
Next question. Is it best to not get the Mirena again if it caused a lot of pain in the pelvic area, such as stabbing pains or pressure that was worse than normal cramps? So if it wouldn't be a good idea to get Mirena again, what would be a better option to avoid, I guess, those pains while on birth control?
Sure. So the Mirena IUD is going to be your largest IUD. So you could potentially go to the Kylena or the Skylar, one of the smaller IUDs, which might fit a little bit better. Also, if the Mirena was put in, but it wasn't in the right spot when it was there, it can cause a lot of pain and bleeding. And sometimes putting another one and verifying that it is in the right spot, either under ultrasound guidance or just going in with a smaller IUD may actually solve that problem.
And the next question is the only cause of sores on the vagina an STD?
No, not necessarily. You can get skin abscesses in that area. You can get something called a Bartholin's gland cyst, which is an infection of the glands that feed into your vagina. So no, there are other uh, disease processes that can cause similar symptoms.
Um, does birth control, any form, affect fertilization after taking it for years? So does it affect your fertility?
So no, unless you have complications with such like an IUD where you have PID, it should not prevent you from getting getting pregnant in the future.
Mhm. Are there specific exercises that can assist with good vaginal health, specifically for menstrual regulation?
So none that I'm aware of for menstrual regulation. There's definitely pelvic floor exercises for like urinary incontinence and pelvic floor relaxation, but none that I'm aware of for menstrual regulation. Now, just exercise in general, not really pelvic floor, does help with cramping and decreasing menstrual flow.
Okay. What accommodations or modifications do OBGYN providers face with
Mhm.
transgendered patients?
So number one, we want to make sure everybody's comfortable with with seeing an OB-GYN provider if they're transgender. We're going to ask more open-ended questions, kind of let you decide how much of the exam that you're comfortable with. So it depends on the patient. And number one, if there's already a relationship associated with that physician, then it's often easier for the patient to feel more comfortable. But we'll definitely make accommodations for whatever patient wants to come in, whoever wants to come see us.
If a patient previously had an ovary removed due to an ovarian cyst, are they still able to have children with one ovary?
Yes, you can still have children with one ovary. You're still going to ovulate. So yes, you can still get pregnant with one ovary.
Okay. So, in regard to birth control methods, specifically hormonal methods or long term methods, do taking these or using these long term increase your risk for any other health concerns?
So not that I'm aware of, unless you get an infection with an IUD. So as we were talking about, an infection with an IUD can cause problems with fertility in the future. So that would be a long-term health concern. But just having an IUD of 5 years has not shown to cause any long-term health concerns, especially something like an IUD where your hormone levels are actually less than if you were taking like a pill or an injection.
Okay. And what about taking a pill long term? Is that going to have any issues in the future, or could you potentially have any health concerns in the future?
So a lot of it depends on your own basic health and how long you're talking. Like if you are in, I'm not putting a lot of patients in their late 40s and 50s on combined oral contraceptive because there are risks associated with that, increased risk of blood clots with the estrogen, progesterone. So yes, it's kind of patient to patient determined on how long we would put you on contraception. Also, the Depo-Provera shot, which is progesterone only, has no estrogen in it. And there have been some studies that have shown that being on that shot continuously for many, many years may decrease your bone density. So that is something that I do talk to my patients about.
Okay, thank you. So you touched a little on postpartum mental health. If
Mhm.
someone does experience a mental health condition postpartum, does that put them at an increased risk for having mental health condition later in life?
So so women that already have some anxiety or depression are at an increased risk of developing postpartum. So that kind of maybe works in a different way in the sense that you're more likely to have issues with postpartum depression. Sometimes it's transient, where there's postpartum blues or postpartum depression for a short period of time, just during those hormonal changes. Other times, postpartum depression can be present for a while. So it's kind of patient to patient. It's a little bit different patient to patient, and sometimes that may be the time when we discover some underlying illnesses that may have been present for a while and just never been addressed.
Okay. And having a newborn can be or is very overwhelming. So, are there specific signs that loved ones can look out for that would maybe indicate that a new mom is struggling mentally?
Sure. So there's quite a few. So we do a depression scale. It's called the Edinburgh scale that we ask patients very specific questions about. Number one, if they're bonding with the baby or not. If they're not bonding with the baby, that's not usually a good sign. If they're isolating themselves from other people or isolating themselves from not wanting to take care of not so much not wanting to take care of the child, but not really bonding to have that maternal connection with the baby. If they're no longer finding any interest or joy in activities that they used to enjoy before, isolating themselves from friends, um, not leaving the house at all. Uh, lots of times, crying all the time, feeling like they're not doing a good job and feeling like they're really failing as a parent, as a mother. And so a lot of those symptoms, and it's hard because being a first time mom or even a second or fifth time mom with a newborn is hard and you're physically exhausted. So some of those are natural of feeling exhausted and, isolating and trying to just do your best during that time period. But a lot of it is also if emotionally you're no longer coping with kind of normal life stressors. So when your family or friends start to notice that that is happening, that's an issue and that needs to be addressed.
Thank you. Okay, next question. How does whether my husband is circumcised or not affect my health?
So not much. It doesn't often affect your health. Occasionally, we've seen some studies that might be increased risk of infection, such as a bacterial infection. Um, and I, and I don't quote me, I'm not 100% remember, but I do believe some STDs are potentially increased risk of transmission to him. I don't know if it's to the female though, but I don't remember that off the top of my head.
If someone has ovarian cancer in their family history, is there anything that would help prevent or decrease the likelihood of developing it yourself?
So ovarian cancer is tough. A lot of this depends on how young that person was that actually had ovarian cancer. in their family. So if it was a person that had it very young, then we need to do genetic testing. So genetic testing can tell us whether your family has a gene that makes you a carrier for breast, ovarian, and colon cancer, and an increased risk for those three. So that is one of the things that you would definitely want to talk to your doctor about if it was someone who had ovarian cancer young in life. And that would be one of the things to know whether we needed to do closer monitoring for you. Some studies have showed that if you do get a tubal ligation or have a salpingectomy where we remove those fallopian tubes, those women have a tendency to have to decrease their risk of developing ovarian cancer in the future. But we don't do that to prevent ovarian cancer. That's just a correlation that we've seen.
Is it safe to begin prenatal vitamins while you're trying to get pregnant?
I recommend it. I recommend you take prenatal vitamins at least a couple of months before you attempt pregnancy, or at least folic acid. So we want at least a couple of months of folic acid in your system before you get pregnant.
Okay. And then as far as the menstrual cycle, again, going back, you mentioned the
Mhm,
importance of tracking to know what is regular for you. Do you
mhm.
recommend any apps, or have you used any apps yourself, or that you recommend to patients to help keep up with the cycle?
Sure. So there's not a specific app I recommend. I think there's tons out there. Just find one that's easy for you to keep up with and kind of gives you a good read. Really, the important parts of the app that you want is to be able to log the first day of your menstrual cycle and have it be able to give you the length from cycle to cycle.
And next question. So when you mentioned bacterial vaginosis, is that something that you check for when you're doing like a well woman or an STI check? Or is that something that your patients will have to ask for?
So we don't routinely screen for bacterial vaginosis. We screen for patients with symptoms because that bacteria can be routine naturally in your body all the time. It's the overgrowth causing symptoms that we would treat.
Okay. Okay. And then how often should someone be checked for STDs?
It really depends on your risk profile. So if your risks are high and you feel like you've been exposed or are wanting testing because um, you've had unprotected intercourse, then you're going to want to get tested for that. And so the timing of how often and frequent really depends on your risk level and whether your partner's been tested or not.
Okay. Thank you. Okay. If an individual relies on birth control to regulate their menstrual cycle, is there a possibility they will have difficulty getting pregnant?
So that's a good question. So if you were put on birth control to begin with because your cycles were always irregular, it may mean, and it depends, if you were put on in your teens and you have been on it for years, we may not really know what your natural cycle is in your mid 20s or older or even 30s. Um, Really, I would recommend, when you're ready to start trying, would have to see. And if you came off the pills and your cycles were still irregular, then it may be more difficult to get pregnant because most of the time, if you're having irregular cycles, you may not be ovulating regularly.
And then another question, if I know certain medications, physicians will tell you not to get pregnant on. I think there's
Mhm.
specific like acne medications. So if a person does become pregnant on that medication, how important is it that they stop that medication as soon as possible?
So it really depends on the medication. And so depending on which medication it is, then we would tell you what your risks are for the pregnancy for that.
Mhm. So there are no more questions in the chat. I'm going to give just another minute or so for
Sure.
people to get in any last questions that they may have. Dr. Patney, do you have any closing remarks that you would like to give?
Sure. Number one, great questions. And definitely, if anyone has any other questions, you guys can let me know and I'll answer to the best of my ability. But I think the most important thing is to be aware of your body. Your health care is important to yourself. and you're going to be the one that's going to be responsible for taking care of your own future fertility and your reproductive health. And a lot of the decisions are sometimes turn into long-term decisions for you. So, and have an open conversation with your gynecologist or your family practice doctor or your pediatrician about any questions that you may have. And it's better for you to have a lot of knowledge, and be able to make those decisions as well as you can with your knowledge.
Thank you so much. We have a couple of thank yous in here. We do have one more question.
Mhm.
What age would you consider to be young for the ovarian cancer question? So earlier there was
Ovarian.
a question that mentioned family history. Would it decrease
Okay.
likelihood? What would be considered a young age for ovarian cancer?
Right. So if if someone developed ovarian cancer in their 40s or younger, that's going to be definitely somebody that would pop out for me to discuss what the rest of their family history looks like. Most of the time, ovarian cancer is going to be older in age, 50s, 60s.
Okay. Well, thank you so much. We're getting a lot of thank yous in the chat as well. We appreciate you so much for taking the time to be here with us today and give this wonderful presentation. I am going to go ahead now and share the last few slides that I have. So I know a lot of times when we leave presentations, it can be a couple hours later or even a couple of days later, but we think of a question that we didn't have an opportunity to ask. So if you do have questions, there was that number listed on the last slide of Dr. Patney's presentation for Kelsey Siebold. You can also send over questions to the Women's Fund at healtheducator@thewomensfund.org. Let me resume share. Okay. Healtheducator@thewomensfund.org. I have also included a survey link here. If you could please provide feedback over today's presentation, it would be greatly appreciated. I have sent the link out to Dr. Hong, so hopefully she will be able to get that to you all as well. But I want to thank you again, Dr. Patney, for joining us
You're
today.
welcome.
And thank you to the audience for your participation and your wonderful questions. If you're interested in learning more about the Women's Fund or seeing any of the upcoming events that we have, you can always visit our website, thewomensfund.org, or follow us on social media to see what we are up to. Tomorrow we have a presentation over teen dating abuse prevention as a part of our domestic violence awareness series for the month of October. We also have a presentation over personal and community violence. And then on the 22nd, we will be presenting over conflict resolution. So if there are no other questions at this time, I will end the presentation here.
Great. Thank you. Thank you for having me.
Bye.